Dr. Worden, can you hear me?
I can.
We are live, so you may begin your presentation.
Awesome. Hi, everybody who's attending. I really appreciate you coming. This is our first live stream for the TOS education channel. I'm Dr. Scott Worden. You may have heard of me. I do a lot of work with MRI diagnosis of Thoracic Outlet Syndrome, and it's become sort of a passion of mine. I have a presentation set up. As the title says, we're going to discuss the anatomy of Thoracic Outlet Syndrome, really the anatomy of the thoracic outlet. It'll be relatively basic. I'll try to keep the medical terminology limited. Some of it will be necessary and hopefully will help you understand if you've read articles about Thoracic Outlet Syndrome, because doctors do use our own language. However, we're going to try to keep it simple and build up from the basics and go forward. I'll also invite anybody to ask a question if they want through the comment section. We'll answer as many of those as we can. So let me get the presentation queued up and we will start. All right, here I am. My name is in lights. Anatomy of Thoracic Outlet Syndrome. Going to take three basic points to cover here. Where is the thoracic outlet? What is the thoracic outlet? And then briefly, we'll touch on what is Thoracic Outlet Syndrome, really because it's just a function of understanding the anatomy to understand Thoracic Outlet Syndrome. Let's start. Where is the thoracic outlet? Well, everybody's probably pretty comfortable knowing that spot that's just above your collarbone on the side of your neck. It's this little hollow space right in here. Now, obviously, it looks a little bit more complex when we add in all of these structures, but we'll get to these in time. As I said, we'll build from the bottom on up so that we can all grasp the basics. Take a look at the bones right here. We're going to start with bones because that's pretty simple. And we're going to use the bones to help us define the boundaries of the thoracic outlet. Now, I'll give you a little warning. Not everybody agrees on these boundaries. Anatomists in general, scientists who study anatomy and variations, will call this the thoracic inlet because things go from the neck into the thorax. But in general, clinicians, doctors who practice, and people who publish papers on thoracic outlet syndrome have always called it the thoracic outlet because the blood vessels come out of the chest into this area. So let's take a look. We'll see that we start from the lateral edge of the spine. The floor is just above the first rib and the lung. We keep it in these soft tissues. And here we see the armpit or axilla, where the structures that enter this thoracic outlet leave the thoracic outlet and enter the arm. So these are the basic boundaries using bony landmarks of the thoracic outlet. And of course, you have one of these on each side of your body. So pretty simple. Now let's talk about what is a thoracic outlet. We'll start by talking about the intrinsic structures within the thoracic outlet. And then we'll talk about the structures that have to pass through the thoracic outlet. And these are critical because involvement of these traversing structures is what causes the symptoms of thoracic outlet syndrome. Then we'll talk about the tunnels that have been classically described. The traversing structures normally pass through a series of tunnels to get from the neck and chest through the thoracic outlet and into the arm. So those tunnels all have names. We'll talk about those. And we'll touch briefly on the dynamic changes that occur in the thoracic outlet that really don't occur anywhere else in the body. All right, intrinsic structures will include the bones, as we just saw, the muscles, the top of the lung, and some other soft tissues. We'll go through these step by step. We're going to start with the spine. Everybody knows what a spine looks like. We're going to focus on the upper part of the spine called the cervical spine. Just means the spine in the neck. And that's what you can see here. The cervical spine is very simple. We're going to look at the first rib, which curves from the cervical spine around the front. The clavicle is also known as the collarbone. The scapula is also known as the shoulder blade. Forgive me, as a practicing doctor, I'm always using these fancy words, but most people would call a clavicle a collarbone, They call a shoulder blade, not a scapula. So I hope you notice that the first rib extends from the cervical spine or just below the cervical spine, and it curves around to the front to join the sternum or breastbone. It forms a really strong strut between these structures, and there's one on each side. Here's the first rib on the other side. The collarbone or the clavicle is very mobile. This is the joint where it attaches to the body. And you notice at the far end is where the shoulder blade or the scapula attaches. So the shoulder blade has a lot of motion to it because it's attached with one joint here and one joint there, kind of like it's on a long flagpole and can do a lot of things. There are actually 17 different muscles attached to the scapula. So the balance of those muscles and the way they're contracting or relaxing will severely affect the position of the scapula or shoulder blade. Now we're going to move on to the muscles. The first muscle, the classic muscle that we all need to know, is called the anterior scalene muscle. Forget this name. It's had a lot of different names ever since Galen in about 150 BC, AD. Here we have the cervical spine. You can see that the anterior scalene muscle has several little points that it arises from the cervical spine. It joins together to form one muscle bundle, and then it comes down and inserts on the first rib, which is right here, the curved structure. And we can see this on both sides in a more realistic drawing. This is the cervical spine. This is the sternum or breastbone, and here's the first rib on each side. We can see that the anterior scalene has several little slips of origin from multiple parts of the cervical spine, and they all band together and insert on the first rib. You'll also notice there are additional muscles that are posterior to the anterior scalene. So let's take a look at those muscles. We've got the anterior scalene here, arises from the cervical spine, and it comes down to the first rib. And we have another muscle back here called the middle scalene. The reason these two are important is because there's a triangular space between them. This is a very important space. We'll talk about it later. It's called the scalene triangle. Obviously, it's in the shape of a triangle. The base is really on top of the first rib. The other two margins or sides are formed by the anterior and middle scalene muscles. And you can see the nerves would come out from the cervical spine, and they would pass through this tunnel between these two muscles. The next most important muscle is going to be farther laterally. Now we can see the first rib up here, the clavicle here. This was the space we were just looking at. Those scalene muscles are not shown in this picture. But a little farther out, we see this pectoralis minor muscle. It starts at a little part of the scapula or shoulder blade. It inserts on the second through fourth ribs. So it sort of fans out. The important thing is that it holds onto the shoulder blade and the chest. So those muscles we looked at are going to be the key muscles. This is another picture of the pectoralis minor. Again, right here. See an arrow show up in a minute. It arises from the scapula or shoulder blade up here, comes down to insert on the ribs. And now what this one shows you is how the brachial plexus or the nerves, the subclavian artery, subclavian vein all pass behind this muscle. It's another tunnel we'll look at in a little bit. And do recall that the lungs fill up the chest, and at the bottom of the thoracic outlet, right where the vessels and nerves would be, is also the top of the lung. So uncommonly, people can get a tumor of the lung that may affect the brachial plexus. Now, that's not thoracic outlet syndrome, but when you have the symptoms of that, one of the things your doctor should look for is whether you have this type of tumor in the lung. So now we're going to the second part, the traversing structures. There's nerves, arteries, and veins. And their specific names, it's not so important. I'm sure you've all heard of the brachial plexus if you've studied TOS at all. The subclavian artery and the subclavian vein. Three structures that are the most critical here. Quite simply, this is the brachial plexus. There are 5 different roots that come out of the cervical spine. You can see these side holes. They branch and network and form all kinds of complexity before they pass over the first rib, right here, under the clavicle or collarbone, and then under the scapula or shoulder blade where they enter the arm. That is the brachial plexus on each side. Then we have the subclavian arteries, obviously right here. We also have the anterior scalene muscle right here, arises from the cervical spine, inserts on the first rib. And finally, the third traversing structure would be the subclavian vein. And rises from the chest, passes this way, actually underneath that collarbone. I don't know how well you can see that here, but over the first rib and under the collarbone to reach the arm. All the blood that comes back from the arm to the body or the heart, the vast majority of it comes through a normal subclavian vein. But subclavian veins can be compressed in this space. And sometimes that compression can lead to a blood clot within the vein, which is venous thoracic outlet syndrome. Not going to go into great detail here for that. This is what it looks like with all 3 structures together. We have the nerves or the brachial plexus, we have the artery, and we have the vein. And they're in a pretty tight space once they get out here. They pass between the scalene muscles for the most part, between the collarbone and the rib, and then behind this pectoralis minor muscle. We're going to talk about that in detail. Here's another quick picture of the nerves, arteries, and veins. They're pretty closely connected one another, but there are some important differences. So now let's get to the tunnels. We've seen some of the basic intrinsic structures of the thoracic outlet. Now we're going to talk about these classically defined tunnels. There's 3 of them. These names aren't critical, but these are the 3 names. And we'll go back over them. Okay? This would be a patient whose left shoulder is out this way. Obviously, this is their cervical spine, and we're looking at the left thoracic outlet. First thing we see, and what we always want to see, is the anterior scalene muscle. In this case, we also see the middle scalene muscle. Here are the bony structures, first rib, and the clavicle. You'll notice that there is a triangular space here, outlined by this purple marker. The base is at the level of the first rib. The anterior margin is the anterior scalene muscle, and this posterior margin is the middle scalene muscle. And you'll notice that between those 2 muscles, we have the brachial plexus and the subclavian artery. But the subclavian vein actually passes in front of the anterior scalene muscle. I hope that's clear from this diagram. We'll take another look at a different diagram. And this is just to outline those 3 critical structures. Brachial plexus is the nerves. We have an artery and a vein. Notice that once these 3 structures leave the area of the scalene muscles, they will cross over the first rib, which is partially obscured here. So between the first rib and the collarbone or clavicle is going to be our second space. The first space is this scalene triangle. I'll show it to you again. The second space is right here between the rib and the clavicle, and we'll see this soon. This is just a lateral view, as though we're looking from the shoulder to the side of the neck. The patient's chin would be up here. The breastbone or sternum is here. And now we can see the labeled structures. We have the anterior scalene. We always want to find that. The middle scalene and the 2 bones. We now see the first rib curving from the spine anteriorly towards the sternum. As I said, it's a curved, fixed structure, mostly fixed, and it's a pretty strong strut that holds things together. Now this is normal. What we're going to see here is the scalene triangle again. The base of it is the first rib. This wall or margin is the anterior scalene, and this wall is the middle scalene. Again, I want you to notice that the 2 structures that pass through the scalene triangle are actually going to be the subclavian artery and the brachial plexus, but the subclavian vein passes in front of the anterior scalene. Now, as I mentioned, there's a second space here. Right after you leave the scalene triangle, the important structures pass between the clavicle and the first rib. And this is called the costoclavicular interval. Costo means rib. Clavicular, of course, means clavicle. But you'll see this noted in a lot of reports about patients with thoracic outlet syndrome. Again, to repeat, the first space is a scalene triangle. The second space, or tunnel, is the costoclavicular interval. Now, the costoclavicular interval contains all three structures: the subclavian vein, subclavian artery, and the brachial plexus. Remember that the scalene triangle only contained two of those. Okay, this is the last space. The pectoralis minor attaches to the shoulder blade or scapula. And now we see what's called the retropectoralis space. Again, this is the pectoralis minor. Behind it is the retropectoralis space. And all three structures pass through this. You'll see the brachial plexus, the subclavian vein, and the subclavian artery all come through this space behind the pectoralis minor muscle. So this is the farthest out towards the shoulder. Once the three structures get past this space, they're actually in the arm. So it's no longer the thoracic outlet. Now we're going to touch on the dynamic changes. The arm is the most mobile joint in the human body. And when you move your arm, the shoulder blade moves and the collarbone moves, but the ribs really don't move. So you have this relative motion of the collarbone relative to the first rib, and that can create problems, meaning it can create compression of any of those structures, which causes the symptoms of thoracic outlet syndrome. So I'm going to flip back and forth between these two structures. Just to remind you, these are the scalene muscles here. This is the collarbone or clavicle here. The first rib is a little hidden underneath here, but it goes underneath the three vital structures. And this is the pectoralis minor with the retropectoralis space behind it. This image shows the patient's arms down by their side. And this image shows what happens when you raise your arms. The collarbone, you'll notice, gets quite close to the first rib in some people, and it can compress these structures right here. That would be the costoclavicular interval. So right here is the scalene triangle. Two of the structures go through there. This is the costoclavicular interval between the clavicle and the rib. And this is the retropectoralis space, where the pectoralis minor muscle sits. So you may get compression in the scalene triangle or compression in the costoclavicular interval between the rib and clavicle. And then you can get tension. You can imagine how this would pull tight on the nerves or the blood vessels. I'm going to go back. This is with the arms down. And this is with the arms up. So those dynamic changes may contribute. I'm going to show you one more time. Let's try to focus on the first rib. Here's the neck of the first rib there. On the other side, you'll see the full first rib without the soft tissues or the collarbone overlying it. Let's go back. First rib is here. We don't see it as it passes under these soft tissues. But when I change in a second, with the arms up, you'll notice the rib doesn't move, but the collarbone does. And that's why we can see this narrowing of spaces in some people with thoracic outlet syndrome. Now, quickly, we're going to touch on what is thoracic outlet syndrome, and I've kind of hinted at it. I don't want to get in detail because a later live stream will go into it in great detail. But in general, you can read this. When you get compression of those three vital structures and it causes symptoms, that is thoracic outlet syndrome. And there are three types. I'm sure you've all heard that. But depending on which structure or structures are compressed, we can get any one of these or a combination of them. It doesn't occur in isolation all the time. But by far the most common type is neurogenic TOS, where the brachial plexus is compressed. And that's also the hardest one to clinically diagnose. That's why the MRI that I perform has so much value. It helps doctors understand what's going on inside. So let's compare a normal person on the left to a person on the right with TOS. We can see the normal anterior scalene muscle and the normal space between the collarbone and the first rib in this normal person. In the person with symptoms, we see a thickened or inflamed or injured anterior scalene, and we see the collarbone has now come much closer to the first rib. So this patient could have symptoms because of the thickening of the anterior scalene muscle, but they could also have symptoms because this space in here is tight. So I hope that ties together a lot of what we discussed in terms of the anatomy. So to review, we talked about where the thoracic outlet is and the boundaries of it. We talked about what is the thoracic outlet with all the intrinsic structures, as well as the structures that traverse the thoracic outlet, the nerves, artery, and vein. We talked about the dynamic changes that can occur with arm motion. And then we briefly touched on what thoracic outlet syndrome is. So I want to thank you for your time, and we're glad to take any questions. And if not, we look forward to seeing you for our next educational session, which is with an excellent physical therapist named Steve Talikowski, who studied for years with Peter Edgelow, and he carries on the torch of the Edgelow technique. So I hope you can still hear me. I have a question here I'm going to read to you. First question says, I'm a 14-year-old swimmer from California. My doctor thinks I may have TOS. How do I know for sure? So the things I'd recommend would be, number one, make sure that the doctor you're seeing is an experienced TOS specialist. There are a lot of doctors, unfortunately, still who believe that TOS is controversial, not for any good scientific reason. And I think they're quick to dismiss the diagnosis and tell you to go on to something else. Many of the patients we've dealt with have been through a bunch of doctors like that, and it's very frustrating. It's a formula for depression when you have chronic pain and somebody's telling you it's not real, that it might be in your head. So first thing is, go to the websites that are now available and find an experienced TOS specialist. Of course, I recommend our MRI scan if your TOS specialist believes that you have a good chance of TOS. I think that our MRI shows all that anatomy beautifully, as well as pathology, the abnormal anatomy, the abnormal changes that occur when you raise your arm. So I think that's tremendously helpful to other doctors. When it comes to treatment for TOS, that's an entirely different discussion, which we will get into in a later seminar. But I hope that's a start as an answer to your question. The next question is, can pregnancy directly cause TOS? Or rather, can the onset be caused by pre-existing conditions, such as repetitive motion, and then present during pregnancy with the relaxed structure from hormones? So that's a very interesting question on a lot of levels. It shows some thought. And the question is, there's not a lot of literature that documents it. First, there is no gold standard diagnosis clinically for TOS. There are papers out there that show these signs, Adson's sign, the Wright test, the Ruse test, that they're fair but not great, and they don't definitively diagnose TOS. On top of that, it's my firm belief, and with a lot of the progressive TOS specialists around the country I know, that TOS is not one disease. There are different little mechanisms within that space that's very complex. And different mechanisms can cause different types of compression or tension on the nerves or the blood vessels. So docs can't put their fingers on those structures and really feel the anterior scalene abnormalities like we can see on MRI. Now, having said that, a good example in the literature is that carpal tunnel syndrome is clearly associated with pregnancy. Many women, when they get pregnant, tend to retain more fluid. If you have a tight space in your wrist, the carpal tunnel, and it's just enough for the nerve to go through with all the tendons, But then you add the edema that comes from this water retention during pregnancy, the symptoms will start to show up, and that will be carpal tunnel syndrome. Generally, doctors won't do surgery for that because pregnancy is temporary. So in the thoracic outlet, we do believe that there is edema or swelling in the soft tissues that shows up. And if you have a predisposition, like the anatomy is a little too tight, and you've been doing repetitive work, like all of us use computers in non-ergonomic positions, I do it myself, or we're holding iPads while we're in bed, or we work with computers all the time and our company doesn't provide us the ergonomic environment. It's very challenging, actually. Laptops are impossible to be ergonomic with, for example. Your hands and eyes are not far enough apart. So if you have that kind of prehistory, then the superimposed soft tissue swelling from pregnancy can certainly bring on the onset of symptoms, although, again, I don't have literature that supports it. Another question we have is TOS both a clinical diagnosis and an imaging diagnosis? Is it possible that imaging alone cannot pick up some cases of neurogenic TOS? So the answer to that in the medical literature is a little complex. Number one, there is no gold standard. As an example, let's say you did a CT scan of the brain and you wanted to diagnose a certain type of cyst in the brain. You would have a study where you would make this diagnosis. You'd have a couple of radiologists read head CTs and they'd make their best diagnosis. And then you would compare it to the surgical results after the surgeon takes out the cyst and the pathologist looks at it. There you have the gold standard. The pathologist studies under the microscope and may do specific stains, and they can say 100% this is or is not cyst XYZ. Then you go back to the head CT, and you see how many times the radiologist got it right. But we don't have that standard for thoracic outlet syndrome. There's no pathologist who looks at the nerves and says it. So it's hard to compare the results of any imaging study directly to that. Nonetheless, we do have a model in radiology. There's something called the nerve entrapment. Carpal tunnel syndrome, I talked about a little bit before, is one example. And we know the patients get symptoms. We found some anatomic abnormalities in the carpal tunnel. We can do an electrical test called a nerve conduction study, or EMG. Some of you may have had that. And clinically, a doc will say, let me get an MRI. And over time, radiologists have figured out what types of things on MRI correlate well with the symptoms and the positive EMG test. So now we have a pretty good idea when the patient has the right symptoms and you find these anatomic abnormalities, like perhaps a bone spur on MRI or CAT scan, that equals carpal tunnel syndrome. And this happens all over the body. For some reason, in the thoracic outlet, there's a lot of docs who hesitate to let the imaging work with their clinical judgment. But it's like every other entrapment neuropathy. Basically, if we find abnormalities in the thoracic outlet, then we can correlate them with the findings on clinical examination. And if we don't specifically diagnose it 100%, we're certainly increasing the confidence of your doctor when he or she thinks it's thoracic outlet syndrome. So I think it's a very valuable test. It can also see small things that your doctor could never find by physical examination. It may also rule out other causes of TOS, although I don't believe that's its primary purpose. Generally, doctors can tell if you have carpal tunnel syndrome rather than TOS, although carpal tunnel syndrome may be caused by TOS. Next question is, does joint hypermobility play a role in developing TOS, and can it impact recovery? And I would say that, hang on one second. Okay, so I have heard from several doctors, and we have had several patients referred to us who have one hypermobility syndrome, and it seems to be unusually high without having statistics on it. I would say because we're so worried about the space in the thoracic outlet, that if you are hypermobile, that the spaces can get constricted more than they would in a normal person. And this would raise the concern, increase the concern that it may contribute to TOS because you, if you're hypermobile, can do more than a person who can't move that much. This space in some people is very sensitive to the position of the arm and the shoulder. They could go into great detail about that. It's fascinating, and it's not as well studied as we'd like. But again, the progressive TOS specialists around the country tend to agree with me that we have an issue with abnormal motion of the shoulder blade, which causes abnormal motion of the collarbone. So yes, I think hypermobility may contribute to TOS, that it wouldn't in a normal person with the same spaces. And can it impact recovery? That question is a little out of my league since I don't practice clinical medicine anymore directly, but I talk to my doctors. So I think if you follow a good conservative therapy protocol, you would learn as part of that biofeedback, and you would tend to control the hypermobility on that one side. I hope that answers that question. The next question is, can TOS cause muscle imbalances to form and therefore cause compensation patterns in the body as a whole? It's a really excellent question. Number one, yes. And if you want more detail, I'm happy to give it, but I'll try to limit it because I could talk forever about this. So if you shift the position of your shoulders forward and you hunch, as people tend to do with TOS, because they're relieving the tight spaces in there by doing this. Number one, the muscles that you're shortening, like the pectoralis minor, will stay shorter. Unless you stretch all the time and keep yourself in good posture, those muscles tend to shorten, and then it's very hard to get them to release. The other thing is when you're leaning forward, your posture has to change if you're walking and standing, even when you're sitting. But imagine when you're standing and how much balance you have to be right over your feet. So then you'll change the position of your lumbar spine or lower spine, right? You might bring your head to a new position. So it clearly affects posture. In the talk next week with Steve Talikowski, he'll cover one of those things, which is posture. He corrects posture, he addresses posture, he tries to raise awareness of it in each person so they can start to correct. So posture is one. The second part, compensation in the body as a whole, absolutely. You will react to pain. You will guard. You will take a posture, whether you're sleeping, working, standing, walking. You will assume a posture that has the least amount of pain. And the muscles that you shorten will stay short, and the muscles that you lengthen will tend to feel pain because you're lengthening them abnormally. If you take the short muscles and you try to stretch them and make them longer again, it can be very painful, and it's very hard to do without help. And hope you can see my son kind of checking in my office. He wants me to sign into his iPad and give him more time to play a game. Kai, can you ask your mom to help you?
She's not here.
Okay. Excuse me for 1 second. Can you say hi to everybody who's watching?
Hi.
What's the thing that I study, Kai?
I forgot what it's called.
TOS. Thank you. Okay. Thanks. Sorry for the interruption. So we were touching on muscle imbalance and compensating with your body as a whole. And yes, the answer is absolutely yes. Dr. Tracy Newkirk, who will speak in a few weeks, finds a certain population of patients who actually have lower extremity symptoms that are very repeatable, and it's a common pattern. And it doesn't make sense why that should occur just from compression of the brachial plexus. But there are ways to tie those two together because of these abnormal changes as your body reacts. So we have a follow-up question regarding pregnancy. It says this: carpal tunnel ruled out when pregnancy and edema ceases, and TOS diagnosis is still present. Could pregnancy cause it? Thanks. I understand your question. And if you're having pain, don't type too much, but we want to help. So there's a phenomenon called double crush syndrome or multiple crush syndrome. If you press on a nerve in one spot and then you look farther down the nerve, that nerve may be too sensitive, and a normal amount of compression may cause pain. So in other words, if we take my thoracic outlet here and we cause pain in the nerves, then we look down the arm, I could have apparent carpal tunnel syndrome. And there are a significant amount of cases in the literature where people were diagnosed with carpal tunnel syndrome, got surgery, and got better, and then it recurred because the real problem was up here in the thoracic outlet. So double crush, you press the nerve one spot, and the rest of the nerve becomes too sensitive. So it's possible that a person could have a diagnosis of carpal tunnel syndrome that's really more related to the proximal compression in the thoracic outlet. And then after those symptoms go away, they could come back, or they could come back more proximally. Now, again, the question of pregnancy, there's not a lot in the literature, but I think you would approach it the same way. Get a TOS specialist who's fairly comfortable with it to review your records. And then imaging, if they consider it and if they trust the imaging and work with a good radiologist, hopefully me, it's either there or it's not. It hardly matters whether you had the pregnancy or not. If we've got compression, we can show that. I hope that's helpful. Next question. Please explain PMR surgery, and if a person had bilateral first rib resection and still has pain, would you recommend the pec minor release? So PMR surgery is pectoralis minor release. I'm presuming, I haven't seen that abbreviation. The person also asks, Canadian doctors don't necessarily believe in pectoralis minor release. So we could get into that a little bit. Maybe you can answer me back with a comment. Do you want me to show you the images of the pec minor? And if not, I'll just describe it in words, but I'll start out that way. So the three tunnels we talked about are the scalene triangle. Once the nerves leave the spine, they enter the scalene triangle. Abnormalities of those muscles may compress the nerves. Sometimes the nerves, you're just born with the nerves going around the muscles or through them. It's a very tenuous situation where injury to the muscles can cause compression of the nerves because they take this funny course that is not the normal course between the muscles. The second space you get to is the costoclavicular interval between the clavicle and the rib. And that's a very dynamic space, and compression can occur there and be very severe because it's bone against bone. And the third space out towards the shoulder, okay, out far here, is the pectoralis minor space or the retropectoralis space. Now, a lot of surgeons will say that the nerves and the blood vessels get compressed in this space. But for a lot of scientific reasons, also my experience reading tons and tons of these studies, it's actually very rare to get compression of those structures. It's much more likely two other things happen. Either the brachial plexus and the blood vessels gets pulled underneath that bone. I showed you a bone that the neurovascular bundle, plexus and the artery and the vein, goes underneath, and that can be pulled tight against that, creating tension. But another factor is doctors have found in the past, if they release the pectoralis minor, in other words, if they snip it off the shoulder blade, that the patient gets better. The assumption has been that it's reducing the compression, but in fact, I have a lot of strong reason to show that it's not reducing compression. That space is wide enough. What that technique is doing is it's actually allowing the shoulder blade to relax in a different direction, which opens up the space between the collarbone and the rib. 1950, a guy named Jerry Lord was the first one to do this, called a pectoralis minor tenotomy. It's the release. And he had good results from it. And to this day, we get patients with good results. But I don't think that the reasons are fully understood. So to hit your question again, please explain pectoralis minor release surgery. We talked a little now. And if a person had bilateral first rib resection and still has pain, would we recommend the pectoralis minor release? So I think that in that case, we'd want to do clinical tests with someone who's experienced, and we'd want to get imaging. Number one, we can image the thoracic outlet after surgery. There are a lot of times that there are post-operative changes that can still compress the brachial plexus. So we want to rule that out. The next thing is some doctors will do a pectoralis minor injection. They'll inject a local anesthetic into the muscle and let it relax. And if the patient gets reduction or relief of symptoms, that will lead the doctor to doing something further. I don't think it should always be surgery, but that's one of the things they use it for. So it's a complex question. Thank you. It's a good question, and it's a complex answer. We could go more into it, but I'm glad that you at least brought it up so people get an idea of what we're talking about. Next question is, an EMG showed the ulnar nerve and C8. Is that true neurogenic thoracic outlet syndrome? Okay, true neurogenic thoracic outlet syndrome is not real. There was a guy named Asa Wilborn at the Cleveland Clinic in the 1980s, a very well-respected neurologist. And I want to go back 200 years, 1818 actually, a little more than 200 years, when TOS was first described. I'm a big fan of history, and I found cases dating back a really long time. I just got a paper in the literature that I've been searching for years from 1831 with a good case of described neurogenic thoracic outlet syndrome. Nonetheless, you can go back 200 years, and there are a lot of some of the most famous people in medicine studying thoracic outlet syndrome. Famous people. You might not know them, but I do, because they're famous in my field in medicine. In the late 1980s, Dr. Asa Wilborn, a very widely known neurologist at the Cleveland Clinic, a place with a good reputation, he took a bunch of patients with the diagnosis of TOS, and he did this EMG, or nerve conduction velocity study. It's two different parts of one test. And he couldn't get good results. So he said, my EMG is negative, therefore all these patients with symptoms are faking it. And all the surgeons who treat them are just doing it for money. And that's a pretty striking accusation. There's, of course, another possibility. Maybe all the patients had negative tests because the test just doesn't work. And in fact, we've got pretty strong evidence that that test just isn't very good. Without going into the details, you can do this for carpal tunnel syndrome, and it's great. But physically, you can't get the electrodes, and you can't do the whole thing way up buried in the neck where the brachial plexus occurs. So it's really hard to do this test technically, and you only get indirect signs. So EMG by itself isn't great. But what Asa Wilborn did was he said, I'm going to talk about 4 types of TOS. 4 types. Arterial, venous TOS, and then 2 types of neurogenic TOS. One is the true type, where my EMG is positive, and one is the disputed type. Disputed. So he put this pejorative term on it. So basically, if you have a positive EMG and you have all the symptoms, most docs will agree it's neurogenic TOS. Unfortunately, that EMG often becomes negative only when you have motor nerve damage. Sensory nerves feel things. Motor nerves activate the muscles. When you get motor nerve damage, it's very hard to recover. If you have just sensory nerve damage, which occurs first in most cases, you can recover and you don't lose motor function. So to wait for an EMG to be positive is not a great approach. Every other entrapment neuropathy in the body, when a doc finds it, he or she doesn't wait until there's motor nerve involvement. So now the disputed form of neurogenic TOS, he says if it doesn't have a positive EMG, I'm disputing it. And that's led to a whole bunch of docs saying, I don't have to read about this disease. It's too complex. And besides, it's disputed. Okay, so the terms true and disputed should be a red flag. If a doctor uses those and doesn't understand the real significance, then you're missing something and you might want to consider a different doc. Most docs will not talk about disputed TOS. They know that EMGs are not a great tool for this study. Maybe they'll show something else, but a good doc will already know it's probably TOS, and they don't need to exclude carpal tunnel syndrome or cubital tunnel syndrome at the elbow. They've got an idea it's way up higher in the neck here. So really, to answer your question, if the ulnar nerve and C8 are showing up with positive EMGs, that's helpful, but it could be due to cubital tunnel syndrome at the elbow. It could be due to TOS. It's just, I don't think it's necessary, and it doesn't answer the anatomic question of what's going on in your thoracic outlet. So I think imaging, again, is a tremendous adjunct or help if your doctor suspects TOS. We get another pregnancy follow-up. I don't know if we have a bunch of pregnant visitors here or people who are pregnant or if it's coming from the same person, but I'm glad to answer these. Pregnancy follow-up, and I'm reading it the way it's written to me. Onset was motor vehicle accident. TOS was confirmed by a specialist. The insurance company has declared that TOS onset was due to pregnancy. And thank you from the patient. So I can't give specific medical advice for any one of you. I'm giving general ideas of what we talk about here. And I can't give you a specific diagnosis. But what I can say in general is that a careful review of your records to show the timing of symptoms would be very important. Of course, if the motor vehicle accident occurred after the pregnancy and there was a sudden onset of symptoms, that would be tremendously valuable because temporally they're related. But it's also possible that pregnancy was there and caused a flare of something that hadn't been there before, and the motor vehicle accident is entirely independent of that. I don't see any literature, medical literature, that shows a way to diagnose TOS due to pregnancy. I try to get copies of all these papers that come out. I do not recall any paper that has any kind of diagnostic confidence that pregnancy caused it. And therefore, for the insurance company to say, you have to prove us wrong, it should really be going the other way, maybe. Okay, that if the insurance company has some person who has some knowledge I don't, and some literature in the medical literature that says these are the signs that pregnancy caused this, okay, but they'd have to prove that to you, because otherwise I've never heard of that diagnosis being forced. Okay. Next question is, would too many Botox injections in the scalene muscles lead to cervical instability over time? That's a little out of my field. There are pain management specialists who do lots of Botox injections and injections of other medication. But my understanding from the TOS literature is no, that Botox can work great. It can really loosen those muscles. So they used to use it in the anterior scalene. They still do. Some people use it in the pectoralis minor, as we discussed before. And it can cause great relaxation of those muscles, which can help with a patient who's in pain and wants to get to physical therapy. Some doctors have used it as an indication to go to surgery, and I think the evidence in the medical literature on that is weak. Won't go into the details. But after your first injection of Botox, the next one generally doesn't last as long, and the third one, so most people don't get a lot of them because they lose effectiveness over time. In terms of instability, I have never heard of somebody having a problem even when their anterior scalene is taken out at surgery. There's no literature that I know of that says you get neck instability from that. So even if the Botox really relaxed the muscles, I do not think there is any medical literature that says it would create instability of the spine. However, repeated injections of Botox tend to lose effectiveness. And so in this question, I don't know if you've had more than one injection, if your doctor is recommending more of them, but just be prepared that they tend not to last as long. Next question. How do you support your shoulders and head with TOS and can't add muscles to existing tension? I'm guessing that what you're asking is, how do you keep yourself comfortable, your head and neck in good position, and try to relax the muscles at the same time? That's going to get a little out of my field. And I think next week's talk with Steve Talikowski would be great because he works with this stuff all the time. So, I think it's a matter of, generalized orthotics, finding the right pillows and cervical support, like a soft collar that we use sometimes for trauma patients. But I would say to defer that and see if you can visit next week when Steve Talikowski is on here. My MRI has quote unquote loads of space, end quote. The physician says I don't have TOS. So I'm not looking at your MRI, and so I can't afford my professional opinion. Hopefully they did it with your arms down and your arms over your head. If your arms are over your head and the clavicle and the rib don't come too close together, then that space, the costoclavicular interval, is likely okay. But there are other causes of TOS, like abnormal muscles and abnormal nerves that take unusual courses. So there are plenty of other things we look for besides that space. And I will add one wrinkle. There's some evidence in the medical literature, not proven by MRI, but there is evidence that in the normal position, either sitting or standing, the costoclavicular interval between the rib and clavicle gets narrower when you're sitting and standing rather than lying flat. And since most MRI machines have you lie flat, it's probably underestimating the amount of compression that occurs there. I hope that's helpful. Also, I've just been informed, given the wrong time, Steve Talikowski will be here in 2 weeks, not 1 week. But certainly sign up for the mailing list or look at the schedule that's posted on the website. And we've got a lot of really great guests coming up soon. Good. So I don't know if there are any further questions. I'm really glad to have had this opportunity, and I hope it was helpful. Really basic talk to start with, but establishing some terminology. And I have one more question here. Lidocaine to diagnose neurogenic TOS. That's a really good question because people have done what's called a scaling block since about the 1970s in LA. I know several of the people who've done this and published papers on it. And it's still a subject of active debate right now. But what they did at the time was they put a needle into the anterior scalene muscle. It's fairly deep in the neck. And they injected lidocaine, which is an anesthetic that lasts for 5 to 20 minutes, not very long. What we call a short-acting anesthetic. And they found that some patients got relief. They felt better. So they took those patients to surgery, and they had good surgical outcomes. They surmised from this that if you had a positive result from this scalene block using lidocaine by relaxing the muscle, theoretically, that you would have a good result at surgery. And therefore, they say if I do a scalene block, the patient feels better, that's an indication to go to surgery. Now, that's a real problem with the literature. Number one, we don't know where the needle tip was. They didn't have advanced imaging like now. And although some studies have been done since then with ultrasound guidance, still there's a question about where is this material injected. So you put the needle in or near the muscle, you inject an anesthetic, and the patient feels better. It could be because the anesthetic is around the brachial plexus. When your dentist gives you a shot of Novocaine, it's the same thing. They put it around the nerve, and the nerve goes numb, and the pain goes down. So we got to be very careful about interpreting that. There's no solid mechanism as to why injecting lidocaine into a scalene muscle would relieve symptoms. And there's no indication why it would make surgery more likely to work. There have been some theories put forward which just don't hold water to me. You know, my specialty is knowing the anatomy and seeing what happens when you move your arms and trying to put together all the clinical stuff I learned from my contacts of people who do this. I talk to surgeons and other specialists in TOS all the time. I'm always peppering them with questions. It's a tough diagnosis. It needs multiple specialists. And I would say that some of the people who propose mechanisms for why a scalene block works don't have it right. This is my passion or obsession, and I just don't think it's right. So it can make you feel better. Some docs will use it, the scalene block, to say, here's the indication to go to surgery. But I would not count on that if it were me. I think there's more data to be gathered, including MRI. What are they going to operate on? I know there's plenty of big name docs around the country who operate without imaging, and I just have to say, well, what are they going to see when they get in there? What other major surgery would you have in this country without having imaging ahead of time? So I'll stop opinionating on that. Are there any other questions? I'm glad to take another couple of questions. And if not, thank you all for attending, and I hope it was helpful. You can send questions afterwards to the TOS Education website, and they'll get them to me, and I'll be glad to answer as many as I can. Also, my own website is tosmri.com. That's tosmri.com. And I talk a lot about imaging and about the disease, and we take emails there as well and try to answer as many people as we can in the shortest possible period of time. So thanks again. Our first live stream, and it was an experience. And hopefully next time I get to speak to some of you in person. Herb, is there anything else?
I think we're good to go, Scott.
All right, excellent. All right, I'll sign off now. Thank you.